Thank you very much. I would like to thank the organizers and all the president and the secretary for giving me this opportunity. So I think the previous speakers have already spoken about how to diagnose Lisfranc and what you should be doing. So just a quick brief: 30-year-old female, minor fall from stairs, diagnosed with midfoot sprain. Seen by a second physician, diagnosed as fracture of the base of the fifth metatarsal, treated in a cast for 6 weeks. Came to me 3 months later with this kind of deformity. This was the kind of injury she had, and basically the question is, why did we miss the Lisfranc, and this is the kind of deformity, and then how do you treat this patient? Questions to ponder: why are Lisfranc injuries missed? Why Lisfranc joints are important, and what next? So, Lisfranc injury is 20 to 40% of the injuries are not treated in timely manner. They are either overlooked or misdiagnosed as foot sprains. I think previous speakers have already alluded to it. And many times in multiple trauma patients, or because of not seeking medical care or medical negligence, these injuries are missed. And why are these injuries, or why Lisfranc is important? Because if it is not treated properly, they can cause chronic pain and functional loss, and especially deformity. We have seen the type of deformity which you can see. The treatment decision making is either the degree of the deformity, depends on the degree of the deformity, number of affected joints, the soft tissue injury, articular cartilage loss, ligamentous and arthritis present. And what are the options we have as an orthopedic surgeon? Of course, you can conserve them, you can fix them, you can fuse them, and then something called as a biological option. Should Miss Lisfranc be left as it is? Yes, you could leave it. What is your primary goal for us to treat a patient is to make sure that the patient has no pain. If there's any deformity, you correct the deformity and make sure the function is preserved. So for a minimally displaced, low energy, low demand patient, you can continue with a conservative treatment if they are minimally displaced. But the problem is, they can cause painful malunion, broad spectrum of deformity, and impact function. And especially if patient presents late without any degenerative arthritis, which is a delayed diagnosis and a subtle Lisfranc, there is still no surgical procedure that has been universally accepted as a standard treatment of care. And what are the challenges? Why are we talking about this here? Because if you do an open reduction and internal fixation beyond 6 weeks, the problem is there's a lot of soft tissue dissection which is required. If there is an articular surface which is out of the contact, then you can have cartilage loss as well. And you want to fix them, but there is osteoporosis, so the bones are not very good quality. Yes, you can fuse them, but fusion has its own downsides because it sacrifices the physiologic movement. You still on the medial side, especially the first EMT, you still have 4 to 6 degrees of movement which is relevant. Second, third is not an issue. Lateral side needs to be mobile. And if you fuse them, that increases the stress in the surrounding joints and can cause long-term arthritis. Can you fix these Lisfranc even if they come beyond 6 weeks? There's a study of 2016, 8 patients who were fixed beyond 15 weeks and they had no pain or decreased pain, good functional outcome, and they were able to return to sport. So fixation beyond even 6 weeks, good outcome. Can Miss Lisfranc be fixed? Another study, 16 feet, time from injury to surgery, 4.5 months. These Chinese people, they had a 2-stage procedure. First stage, foot frame was applied, joints were reduced, and later on they were fixed where the frame was removed and had a good outcome. Should Miss Lisfranc be fused? Yes, if you have arthritis, if you have significant damage to the articular surface, or pure ligamentous or high energy trauma, it's a no-brainer. You can always fuse them. But what are the other things which you can do? Can Miss Lisfranc be done better? So this is another paper, recent 2017 or 18. 3 patients with time from injury to surgery 3.5 months. They had a biological fixation where they did a 4-bundle Lisfranc ligament reconstruction with gracilis tendon. They had a 2-year follow-up, good results, and able to resume their previous activities. This is not a one-off paper. Another paper with 5 athletes with 10 months or more than 10 months Miss Lisfranc. Lisfranc ligament reconstruction was done again with a tendon autograft. There was no need of another surgery, and they were able to return to their previous athletic activity. So not all Lisfranc needs to be fuse. Now, there was a talk in 2 days back, one of the surgeons said, if you have more than 4 weeks, you can fuse them. No, there are other alternatives present. And how do you do a biological fixation? There are multiple ways you can do it. You can pass a tendon from here, from the base to the cuneiforms. You can loop it around various ways. You can look it up on the paper. So coming back to my case, that was a 3 months post injury. You can see there is a subtle opening up here, and there is definitely subluxation of the TMT joint. I think there is an issue with the videos here, I think, with this laptop, I think. So that was showing the opening up of the second TMT joint. This is how you reduce it. None of the videos are working. Yes, it was working in the preview room. Sorry. Yes, please. So it just shows how even at 6 weeks or 8 weeks, if you have a good cartilage, if you have a good surface and you're able to reduce it, you should attempt to okay, so I'll have to go through the whole thing again. Yeah, much better. This is a better version. Okay, there you are. There you can see the deformity was correctable. You can see that. And here, looking at the joint, I could reduce the joint. That's the first TMT joint. Just last 1 minute. And there also, the first TMT also was unstable. So that was fixed with a medial plate on the medial side and a dorsal plate. That's 6 months follow-up. She came back. She wanted all the implants out. That's after a year and a half. Everything is well maintained, and she was a happy lady. Now, why do we talk about why should we be fixing or treating the Lisfranc first time? Outcome study, though it is of 1990, they just show that only 1/3 of the patients, if they're treated properly in the Miss Lisfranc, they do well. So still, 2/3 do well, 1/3 still don't do well, irrespective whatever you do. So the algorithm of Miss Lisfranc, and when we talk of Miss, it's more than 6 weeks. Low demand, minimally displacive, conserve. Low energy trauma, medial column involvement without arthritic changes. You can still attempt an ORF plus ligament reconstruction if you want to. High energy trauma, displaced, comminuted, and with arthritic, do a fusion. So, Lisfranc, these are his words. Surgery is bright when operating, but it is still brighter when there is no blood and mutilation and yet leads to patient's recovery. Nothing better than the Lisfranc joint. In summary, salvage procedures aim to provide a pain-free plantigrade foot. Only 2/3 success rate, high complications. That is why early diagnosis and proper treatment is important. Thank you.